Good day, everyone. Imagine this for a moment. A middle-aged man walks slowly into the emergency department. One hand is pressed firmly against his chest. His breathing is slightly heavy. Sweat is already forming across his forehead. And then he says quietly, "Doctor, I feel pressure in my chest." Now pause there for a second, because clinically, this is where the real thinking begins. Is this simply fatigue, muscular pain, indigestion, or is the myocardium, the heart muscle itself, beginning to suffer from oxygen deprivation? Because sometimes, behind a seemingly simple complaint of chest discomfort lies the early warning sign of a potentially fatal cardiac event. And this is exactly why understanding angina pectoris is so important, not just for examinations, but for real patients, real emergencies, real lives. Because failure to recognize angina early may allow progression into myocardial infarction, meaning irreversible death of heart muscle. And once that happens, the consequences may become catastrophic: heart failure, arrhythmias, cardiogenic shock, or sudden cardiac death. So today we are going to walk carefully through angina pectoris, its definition, its pathophysiology, its clinical presentation, the different types, how we investigate it, how we manage it, and finally, how to clerk a patient presenting with anginal chest pain. Now, let us begin from the foundation. Angina pectoris is a clinical syndrome characterized by chest discomfort resulting from transient myocardial ischemia, meaning there is temporary reduction in blood flow to the heart muscle without permanent tissue death occurring yet. And that last part is very important because angina itself is not myocardial infarction. No irreversible necrosis has occurred, at least not yet. Think about angina as the heart sending a warning signal, a physiological distress call. The myocardium is essentially saying, "I need more oxygen than I am receiving." Now, to understand why this happens, we must briefly revisit cardiac physiology. The myocardium depends almost entirely on aerobic metabolism, meaning the heart requires continuous oxygen supply to generate ATP, adenosine triphosphate, the major energy source of the cell. Unlike skeletal muscle, the heart has extremely poor tolerance for oxygen deprivation. Even short interruptions in oxygen delivery begin to impair function. And this is where coronary circulation becomes critical. The myocardium receives blood supply through the coronary arteries, primarily the left and right coronary arteries. Under normal conditions, these vessels dilate appropriately through autoregulation, meaning they automatically adjust blood flow based on tissue demand. So when the heart works harder, blood flow increases. Simple, efficient, physiologically elegant. But in angina, this balance begins to fail. Now, here is the critical detail. The most common underlying cause is atherosclerosis, a chronic inflammatory disease involving progressive plaque formation within arterial walls. The process usually begins with endothelial dysfunction, meaning damage to the inner lining of blood vessels. This damage allows LDL cholesterol, low-density lipoprotein, to enter the vessel wall. Inflammatory cells accumulate. Fatty streaks develop. Over time, atheromatous plaques gradually narrow the lumen of coronary arteries, and suddenly, blood flow reserve becomes limited. At rest, the patient may appear completely normal. But during exertion, everything changes. Because the myocardium now demands more oxygen. The heart rate rises, contractility increases, wall stress increases. But the narrowed coronary vessels cannot deliver adequate blood flow. And this mismatch between oxygen supply and oxygen demand produces myocardial ischemia. This is the central mechanism of angina. Now think about what happens at the cellular level. Once oxygen supply falls, the myocardium shifts from aerobic metabolism to anaerobic glycolysis, a far less efficient pathway. This leads to accumulation of metabolites such as lactate, hydrogen ions, and adenosine. These substances stimulate nociceptors, pain receptors. The pain signals then travel through sympathetic afferent fibers into the spinal cord, and clinically, the patient experiences chest pain. But interestingly, patients rarely describe the pain as pain. Instead, they use words like pressure, tightness, heaviness, squeezing, a choking sensation. Most commonly, the discomfort is retrosternal, meaning behind the sternum. And due to referred pain pathways, the sensation may radiate into the left arm, shoulder, jaw, neck, back, or epigastrium. Associated symptoms may also appear: dyspnea, meaning shortness of breath, diaphoresis, excessive sweating, nausea, palpitations, dizziness, fatigue. Now, at first glance, these symptoms may seem nonspecific, but physiologically, they are signs that the heart is struggling under ischemic stress. Now let us move into the major types of angina, because not all angina behaves the same way. Stable angina is the classic form: predictable chest pain, usually triggered by exertion and relieved by rest or nitroglycerin. This typically results from fixed atherosclerotic narrowing of coronary arteries. But unstable angina is far more dangerous, and this is where clinicians become highly concerned, because now the pain becomes unpredictable. It may occur even at rest, it may become more frequent, more severe, longer lasting. Usually this occurs after rupture of an atherosclerotic plaque. Platelets aggregate, partial thrombus formation develops, and coronary blood flow becomes critically compromised. Unstable angina is part of acute coronary syndrome, meaning the patient is now standing dangerously close to myocardial infarction. Another important type is variant angina, also called Prinzmetal angina. Here, the problem is coronary vasospasm, sudden constriction of coronary arteries, sometimes even without major plaque obstruction. There is also microvascular angina involving small vessel dysfunction, and silent ischemia, where ischemia occurs without pain, especially in diabetic patients with autonomic neuropathy. And this makes it particularly dangerous because damage may progress silently without warning symptoms. Now let us discuss diagnosis. Everything begins at the bedside. History first. Always. A careful history often reveals the diagnosis before investigations even begin. Then we proceed to investigations. Electrocardiography, ECG, records the electrical activity of the heart. During ischemia, it may show ST segment depression or T-wave inversion. Cardiac troponins are extremely important because troponin elevation suggests myocardial cell death, meaning myocardial infarction rather than simple angina. Other investigations may include stress testing, echocardiography, lipid profile, blood glucose estimation, chest X-ray, and coronary angiography, which remains the gold standard for visualizing coronary artery obstruction. Management focuses on one major principle: restore balance between oxygen supply and oxygen demand. Nitrates, such as nitroglycerin, produce vasodilation, reducing preload, reducing myocardial workload. Beta blockers reduce heart rate and contractility, lowering oxygen demand. Calcium channel blockers relax vascular smooth muscle and reduce afterload. Antiplatelet agents such as aspirin reduce clot formation, while statins lower cholesterol and stabilize plaques. And in severe disease, revascularization may become necessary. Percutaneous coronary intervention, meaning stent placement, or coronary artery bypass grafting, CAG. But now, let us move from theory into clinical practice, because eventually you will stand beside a real patient, and you must know how to clerk properly. Clerking begins with biodata: name, age, sex, occupation, marital status, date of admission, then the chief complaint. For example, chest pain for 2 hours. After this, the history of presenting complaint becomes extremely important, and this is where Socrates helps structure the pain history. Site: where exactly is the pain located? Onset: did it begin suddenly or gradually? Is it tight, heavy, burning, squeezing? Radiation: does the pain spread anywhere? Associated symptoms: sweating, dyspnea, nausea, palpitations. Timing: how long does it last? How often does it occur? Exacerbating and relieving factors: does exertion trigger it? Does rest relieve it? Does nitroglycerin help? Severity: often graded from 1 to 10. Then we assess cardiovascular risk factors: hypertension, diabetes mellitus, smoking, alcohol intake, dyslipidemia, obesity, sedentary lifestyle, family history of heart disease. We also obtain past medical history, drug history, family history, and social history. Physical examination includes vital signs, pulse, blood pressure, respiratory rate, oxygen saturation, and cardiovascular examination findings. Murmurs, displaced apex beat, signs of heart failure. Finally, everything is summarized professionally. For example, this is a 58-year-old hypertensive and diabetic man presenting with retrosternal constricting chest pain, precipitated by exertion and relieved by rest, associated with diaphoresis and dyspnea, suggestive of stable angina secondary to ischemic heart disease. So in conclusion, Angina pectoris is fundamentally a manifestation of myocardial ischemia caused by imbalance between oxygen supply and oxygen demand. But clinically, it is far more than chest pain. It is an early warning signal, a warning that the myocardium is struggling. And if ignored, that struggle may progress into irreversible cardiac injury. Which is why every complaint of chest pain must be approached carefully, systematically, and urgently. Because sometimes, behind a patient quietly saying, "Doctor, my chest feels tight," the heart may already be fighting for survival. Thank you.